Okay, good morning. We'll go ahead and get started. It's my pleasure this morning to introduce Dr. Elizabeth Paddock, who is a graduate of Cornell University and then Albany Medical College. She did her family medicine residency at the University of Wisconsin in Madison and did an academic fellowship year also there in Madison. She's on the faculty with the family medicine residency program here in Western Montana and also works part-time as a hospitalist here. She also wants you to know that she's an avid skier and cross-country skier and runner. There we go. Okay, welcome.
Good morning. This is a topic on some things I went to a conference recently at the University of Wisconsin, or University of Washington, the other UW, and thought that would be useful to share. I am not a diabetes expert, but I do see a lot of patients with diabetes. So our objectives today are to review current glycemic targets in diabetes, review some of the newer evidence about the older medications, specifically metformin, the sulfonylureas, and the TZDs, and then review some of the newer non-insulin medications recommended as anti-hyperglycemic therapy in the 2016 ADA position paper. Of note, we're discussing only non-insulin oral medication or non-insulin medications for type 2 diabetes. There's lots and lots of other stuff coming through the pipeline. There's lots of new insulins and things like that, but we won't touch on those today. So what is the state of diabetes management in 2016? There's lots of new evidence and treatments coming out, and it can be really challenging to choose the right medication for the right patient. Costs are a huge factor in medication selection. A lot of the newer medications are really costly, and we'll talk a little bit about this. This talk will be case-based, and we'll try and review these older meds and the newer meds. So, case 1, Mr. Smith. This is a 68-year-old male. He was diagnosed with diabetes type 2 10 years ago. Past medical history of high blood pressure, obesity, and hyperlipidemia. He has no known history of cardiovascular or microvascular disease. He's currently on metformin, an ARB, a statin, and aspirin. He feels great. He's not checking his blood sugars at home. Last A1C 3 months ago was 11.8, but he's been exercising, so he got it down to 10.9. So what is this gentleman's A1C goal? There are a bunch of new standards coming out about glycemic targets, and these are based on a number of patient and disease factors. So be thinking about Mr. Smith's goal, and we'll kind of come back to this. So is his goal less than 6.5? Is it 6.5 to 7%, 7 to 8%, or more than 8%? So the sad state of affairs with type 2 diabetes is actually about 2/3 of adults with type 2 diabetes will die of cardiovascular complications. And the real question here is, what is the impact of glycemic control on these cardiovascular events? Basic science and observational data make us think that tighter blood sugar control should result in better outcomes. But a lot of studies looking at tighter blood sugar control are really considerably less supportive of this. So we'll spend a little time reviewing some of the major trials that are forming some of these new guidelines about glycemic control. The first is the UK prospective diabetes studies that was sort of broken into 3 parts. The first is a randomized controlled trial comparing sulfonylureas, insulin, and dietary intervention in 3,867 patients with a new diagnosis of diabetes. The second piece was there was an embedded randomized trial within that study comparing metformin versus dietary intervention in 753 patients whose BMI was greater than 20% of ideal. And then the third piece of this study was the 10-year subsequent follow-up study, which monitored 3,277 participants, so actually 78% of the original cohort, 10,010 from the intensive group, and 379 from the conventional group, and 136 from the metformin intensive group. And there were a couple of really key points that came out of this series of trials. So the first is that blood pressure and lipid control significantly reduced cardiovascular mortality. tight blood glucose control seems to reduce the microvascular complications, but not the macrovascular complications, which are what are killing people. The second study, the 34, is the embedded metformin study. And the take-home from that really was that metformin should be the medication of choice in type 2 diabetes, especially in those with obesity. There was a 36% reduction in all-cause mortality with metformin and a 42% reduction in diabetes-related deaths with metformin versus conventional therapy. And then the 10-year follow-up study take-home was that tighter blood glucose control early on improves outcomes, despite the fact that these two groups, they had the tight control group and the less control group ultimately merged and had similar glucose control, not very far out from the study, but that initial tight control did seem to improve outcomes. So then there were a few other trials that were done. So the ACCORD, the ADVANCE, and the VA diabetes trial. And these were all similar study designs. They were intensive versus standard treatment. They had large populations, and their primary outcome that they were studying was cardiovascular disease. So the clinical question here is, what is the impact of glycemic control on cardiovascular outcomes? And again, 2/3 of diabetics are dying of cardiovascular events. So this is really important. The UK PDS 33, that first study, suggested that glycemic control is less important than lipid and blood pressure control for mortality. So without going too deeply into the details of how these studies worked out, this is the overall study results. And as you can see, blood sugar control really, for most of them, had minimal effect on mortality. And in fact, in the ACCORD study increased mortality with tight control. And the rest were either equivocal. The only one that showed improvement was the 10-year follow-up of the UK PDS. So looking at these three trials, plus the UK PDS data, you have pretty mixed results. So a little bit more on the ACCORD trial. So hypoglycemia seemed to be the driver of the increased mortality in the ACCORD study. Mortality was higher among any participant who experienced a severe hypoglycemic event, regardless of which treatment strategy group arm they were in. And mortality was higher in the standard treatment group when there was hypoglycemia. That said, there was higher mortality in the intensive therapy group, even when they didn't have hypoglycemic events. So what do we do with all of this? And so really the message seems to be that the A1C should not be one size fit all. There was a time where it was everyone should have an A1C of 7%, and we've really moved away from that. And then the 2016 ADA position paper, the American Diabetes Association 2016 position paper supports this. And A1C goals are now based on a number of patient and disease factors and are variable. So this is lifted from that paper, and basically you can see that they're looking at, on the left are when you should have more stringent goals and when you should have less stringent A1C goals. And patient and disease features that kind of are going to help you manage your approach is, what are the risks associated with hypoglycemia and other drug adverse events, disease duration, life expectancy, important comorbidities, established vascular complications, and then patient attitude and expected treatment effort, and resources and support system. So the take home really is that diabetes goals need to be more relaxed if you have multiple comorbidities, have had diabetes for a long time, or are not motivated. And at that point it's reasonable to have higher A1C goals. So a little bit more from the position paper. So they are still saying a reasonable A1C goal for many non-pregnant adults is 7%. And that's level A evidence, which is clear evidence from well-conducted generalized randomized control trials. They do say in there, providers might reasonably suggest more stringent A1C goals if these can be achieved without significant adverse events. That is level C evidence, so not well supported, but if they are living more on that left-hand side of that table we just looked at, they might be more appropriate to aim for a tighter blood glucose control. And then the third one is that less stringent A1C goals, such as 8%, may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy, advanced complications, extensive comorbidities, or long-standing diabetes who it's difficult to attain control. And that's level B evidence. The American Academy of Family Physicians comes out with a little bit more of a clear statement. Patients with existing cardiovascular disease, 2 or more cardiovascular disease risk factors, or duration of diabetes greater than or equal to 10 years should have higher A1C goals because of a lack of benefit and the potential for increased risk of mortality when compared with lower A1C goals. And they put that in their level A evidence, which is consistent, good quality, patient-oriented evidence. So back to Mr. Smith. So he's had diabetes for 10 years. It's very poorly controlled, and he has multiple cardiovascular risk factors. So what is his goal A1C? And really, he's going to be in that less stringent category of probably less than 8%. So he's still not there. 10.9 doesn't put him at the goal, but it does. Our goal is going to be a little bit higher than it would be if he didn't have all these other things. So I think the take home here really is that early intensive control does seem to reduce microvascular complications. So in these patients, it makes sense, new diagnosis of diabetes in an otherwise fairly healthy person, aiming for tight control is reasonable. Early intensive control seems to reduce cardiovascular disease, but takes a long time to reflect that. The UK-PDS is the only one that saw improved mortality, and that's a 10-year trial. Type 2 diabetes with known cardiovascular disease or a long duration of disease may actually be harmed by intensive control. And finally, after a long duration of type 2 diabetes or known cardiovascular disease, your better goals are to get your blood pressure and your cholesterol under control for better cardiovascular outcomes and better mortality in diabetics. So any questions on that before we move to the next? Okay. So next case, so this is Mr. Johnson. He is an 82-year-old male, past medical history of type 2 diabetes for 15 years. He has high blood pressure and he's got some chronic kidney disease. He's currently on metformin and glyburide. His A1C is 6.6%. He's got a BMP with a creatinine of 1.5 and a GFR of 50. So any thoughts here? Is this a safe regimen for this patient? So a couple of things to be thinking about with this one are metformin and chronic kidney disease and your glyburide and your chronic kidney disease and age. So briefly, oral diabetes meds and chronic kidney disease. So metformin in the U.S. is currently contraindicated in males with a creatinine greater than 1.5 or females with a creatinine of 1.4. And we'll actually talk more about that in a few minutes. The SGLT2s, which we'll also talk more about, act directly at the kidney, so they're going to be less effective in CKD. And then, so Mr. Johnson has a creatinine of 1.5 and he's on metformin and glyburide. For the sulfonylureas, use those with caution in CKD, and glipizide is actually preferred. So that may not be the best med for him. So back to metformin. Guidelines are actually quite different in other countries. In the UK, they use a cutoff of a creatinine of 1.7 or a GFR of less than 30. In Canada, they're using a GFR of less than 30, and in Australia, less than 30 with a dose adjustment for a less than 45. And so in 2011, a group came out with proposed recommendations for use of metformin using GFR and not a cutoff of a creatinine. So then greater than 60, no renal contraindications, just check renal function yearly. Greater than 60 and less than 60 and greater than 45, you can continue to use. You may monitor more frequently, so every 3 to 6 months. Between 45 and 30, prescribe metformin with caution. Don't start anybody new. Don't start a new patient on metformin with these numbers, and you really are going to want to monitor that renal function every 3 months. And then if it's less than 30, stop the metformin. And this was what most of the endocrinologists at the UW group were recommending to do. So I think we are going to see this being more and more incorporated into practice, and I think we probably should feel more comfortable liberalizing our metformin prescribing. And this is important because metformin is really the only diabetes medication shown to improve cardiovascular outcomes, which are what kill patients. So again, getting people on the right meds that are going to improve quality or mortality is really important. So back to Mr. Johnson. So for him, I think it would be reasonable to adjust your A1C goal for him. So he was 6.6. It seems like we have a lot of room to maybe take away some of his meds and tolerate a higher A1C. Many meds used in diabetes need to be adjusted or discontinued in the setting of renal insufficiency, and be really cautious with your sulfonylureas. You have an increased risk of hypoglycemia using those in CKD. And glipizide is the safest because it's metabolized in the liver. And metformin is likely safe in the setting of mild to moderate renal insufficiency. I think for this patient, I would probably just stop his glyburide and see what happened. And keeping the metformin on with closer monitoring. His creatinine was 1.55. So a little bit more on metformin. So a reminder on how it works. It decreases hepatic glucose production. It increases insulin sensitivity peripherally, and it decreases intestinal absorption of carbohydrate. There's some interesting newer data coming out, so stay tuned, but there does seem to be some effects on changes in the gut microbiome with metformin. And there's some studies with a modified metformin that you actually don't absorb. It's not absorbed systemically, and it seems to still have a lot of significant glucose lowering effects. So how all this is going to play out is going to be interesting. There's also some studies on some questionable anti-cancer properties as well as anti-aging properties. So take home on metformin, there's some exciting data about metformin's action on the gut, maybe leading to increased glucagon-like peptide and alterations in this microbiota. The 10-year follow-up data from the UK PDS study shows that metformin has cardioprotective effects. And data on significant cancer protection by metformin is not really panned out, but there may be some small benefits. And then there are some new studies actually out there looking at the anti-aging effects of metformin on non-diabetics. So stay tuned. And finally, again from the American Academy of Family Physicians, metformin should be used as first-line therapy to reduce microvascular complications, assist in weight management, reduce the risks of cardiovascular events, and reduce the risk of mortality in patients with type 2 diabetes. Again, level A evidence. So start with metformin if you can. Hold your horses. So she's asking about prediabetes, and we will get there right now. So case 3, this is Mrs. Roberts. She's a 38-year-old female. She's got a BMI of 31, blood pressure of 124/82. Recent labs, she's got a fasting blood sugar of 110 and an A1C of 6.1. She's got a past medical history of gestational diabetes, obesity, and then a family history of diabetes and coronary artery disease. And I would say probably most of us see this patient at least once a day in our office. So just to refresh on prediabetes, making the diagnosis. So generally you need 2 test positives. So if you have an A1C of 5.7 to 6.4, fasting glucose of 100 to 125, a 70-gram oral glucose tolerance test of 144 to 199 at 2 hours, or random blood glucose greater than 200 would make you suspicious. And then the recommendation is to have a second test or to repeat the test to confirm that. So back to Mrs. Roberts, she had 2 tests positive. She had the elevated fasting blood glucose and an elevated A1C. So what do we want to tell her? How do we counsel her? Does she need a medication? So there was the Diabetes Prevention Program. This was sponsored by the NIH through the National Institute of Diabetes, Digestive, and Kidney Diseases. And this was a randomized control trial comparing metformin, placebo, and intensive lifestyle interventions, followed for almost 3 years. There were a little over 3,000 participants who had impaired fasting glucose or an impaired glucose tolerance test. Mean age was 51, obese with a BMI of 34, and majority female. So the intensive lifestyle intervention was 150 minutes of exercise weekly with a goal weight loss of 7%. And so, as you can see, the placebo group did not lose very much weight at all. Metformin did reasonably at 2.1, and lifestyle was most significant at 5.6 kilos. And then looking further at the progression, so 11 per 100, so the number of patients who progressed on to develop diabetes. So in the placebo group, 11 per 100 person years developed diabetes, 7.8 for metformin, and 4.8% for lifestyle change. So there was a 58% reduction in progression with lifestyle changes and a 31% reduction with metformin. So really this tells us that millions of high-risk patients can delay or avoid developing type 2 diabetes by losing weight with regular physical activity and a diet low in fat and calories. And it also suggests that metformin can help delay the onset of diabetes. And I think really this is the question of our lifetime. How do we get patients to do these lifestyle changes? How do we get them to lose 7% and incorporate 150 minutes of exercise? And I'm not sure that, I mean, I think healthcare it's bigger than just healthcare. It's urban planning, it's city planning, it's from above, but certainly we can recommend this to our patients, but it's easy to counsel and hard to make these changes for patients. And so anyway, I'll get on my soapbox there, but this is the challenge of our time, obviously. So the Diabetes Prevention Program and gestational diabetes. So then in 2008, there was a post-analysis of the Diabetes Prevention Program. And it showed that rates of diabetes were actually 71% higher in women with a history of gestational diabetes. And in this group, both the intensive lifestyle and the metformin therapy seemed to reduce the incidence by 50% when compared with the placebo. So there was less of that split where the lifestyle made a significantly bigger difference than the metformin. In the gestational diabetes group, there were about 50% risk reduction using both. So their take-home was that metformin may be more effective in women with gestational diabetes as compared to those who don't have that history. So suggestion in this group that utilizing that metformin may have a significant benefit in delaying the diagnosis of type 2 diabetes. And so out of this stems another recommendation. So metformin therapy for prevention of type 2 diabetes should be considered in those with prediabetes, especially those with a BMI greater than 35, those younger than 60, and women with a history of gestational diabetes. And our goal is really to prevent progression to diabetes. For Mrs. Roberts, strongly recommend lifestyle changes. And again, the ADA comes out and says that same thing. Patients with prediabetes should be referred to an intensive diet and physical activity, adhering to the tenets of the Diabetes Prevention Program with a weight loss of 7% and should increase their moderate physical activity to at least 150 minutes per week. For her, with a history of gestational diabetes and she's younger than 60, you may want to talk to her about using metformin to help prevent development of that. So next case is Mr. Jones. This is a 68-year-old male with type 2 diabetes for 9 years. He has no known complications. He's on metformin and glipizide. His BMI is 38. His A1C is 8.6. Creatinine is 0.67 with a GFR greater than 60. Past medical history of high blood pressure and obesity. And medication costs are a big concern to him. So what now with this patient? So even accounting for age, hypertension, and obesity, his A1C is too high. We still want him a little bit closer to 8 or less than 8. He's maxed out on metformin and glipizide. So what are our options? And just quickly, we have a whole bunch of options. So kind of overwhelming at this point. What do we do with all of these options? And another point here is that the average reduction in hemoglobin A1C with the addition of diet and exercise is 1%. The first oral agent is the most effective, bringing down the A1C of 1.5 to 1.8%. Second agent, 1 to 1.2. Third decreases, and it continues to probably decrease. So even if the advertised A1C reduction is higher, if you're adding it on as a third or a fourth agent, it's going to be less efficacious. So this slide is to show that over time, diabetes becomes harder to control and that insulin levels drop due to beta cell burnout. And this is really important because meds that work to increase insulin production are going to be less effective over time. Specifically, the most commonly ones used are the sulfonylureas. So just a little review on these. These inhibit potassium channels in the beta cells and stimulate insulin secretion. The way I learned about them is that sulfonylureas actually spank the pink. So they make it kick out some insulin. It's like the one diabetes med that I'm like, oh yeah, I know how that works really easily. And based on that previous chart, beta cell failure is seen by 5 years with the development of diabetes. So for most patients on a sulfonylurea, they're probably going to be not real effective by the 5th year. They're pretty effective initially. They reduce the hemoglobin A1C of 1 to 2%, and they're cheap. So for many patients, these are a really good place to start. There are some theoretical concerns that haven't really been borne out, but we may be hearing more about it, is that your sulfonylureas can actually lead to myocardial damage when the heart is stressed. Just that there may be some prevention of adequately coronary vasodilation in the setting of myocardial stress. If you're concerned about that, glipizide is better because it's more specific for the pancreatic receptors, whereas glyburide is non-selective and may affect the heart more. So you might consider choosing glipizide over glyburide if you're concerned. So take home on sulfonylureas, they're efficacious, they're cheap, they're not durable. Most are going to have treatment failure by 5.5 years. Avoid glyburide in older patients and patients with renal dysfunction, and there is this possible association with impaired ischemic reconditioning. Glyburide is renally cleared and is also longer acting, so has a increased risk of hypoglycemia. So I think for me this was a really good reminder because I have a lot of patients who all of a sudden you're like, why is their diabetes just not so well? Nothing's changed. They're saying they're eating the same, their exercise is the same. And then you look back and they've been on a sulfonylurea for 8 years. And and I think our instinct is to leave that on board and start adding other stuff, but it may be worth saying, let's get rid of this and we can switch it to something else or see what happens. It may be that their A1C doesn't budge. So for Mr. Jones, I think for him, because his A1C was too high, we really want to think about changing him to a different agent. And we could think about the DPP-4 inhibitors, the SGLT2 inhibitors, which we're going to talk more about, a TZD. We could consider adding a non-injectable or a non-insulin injectable and maybe thinking about basal insulin. So this is the ADA algorithm, which at first you're like, how is this even helpful? But if you look at it, it actually is a little bit helpful. So these boxes here kind of give you a little bit of background on the meds. So it'll tell you how efficacious they are, what is the risk of hypoglycemia, what's the effect on weight, what are the side effects, and what are the costs. So in that little box, there's actually quite a bit of information that may help you make the appropriate choice. The really small writing that you probably can't read real well there is that if the A1C target is not achieved after 3 months of monotherapy, may proceed to 2-drug combination, and then choices depend on a variety of patient and disease-specific factors. And then they say the same thing for triple therapy. By the time you're thinking beyond triple therapy, the recommendations are metformin plus basal insulin, and then plus mealtime insulin or a GLP-1 receptor agonist. So there's lots of options out there and ways to kind of do this, and this hopefully will give you some info to help pick the right med for the right patient. So alphabet soup of new hypoglycemic agents. So there's the SGLT2 inhibitors, which are your sodium glucose cotransporter 2. These are the meds that end in gliflozin. So canagliflozin, dapagliflozin. Then there's the DPP4 inhibitors, the dipeptyl peptidase 4 inhibitors, and these end in gliptin, so saxagliptin, linagliptin. And then the GLP-1 receptors end in tide. They are injectable, exenatide, liraglutide, dulaglutide. Before we go into these too much, we'll kind of review the TZDs a little bit more, because these were, I remember learning about them in med school, and then kind of during residency they were more or less shunned, and they seem to be making a resurgence in ability to use. So these are pioglitazone and rosiglitazone are the two that remain on the market. These are peroxisome proliferator activated receptors, which basically work to move fatty acids into fat cells, so muscle and liver cells are more dependent on glucose, resulting in increased insulin sensitivity. And they're really effective at reducing blood sugars. They bring the A1C down 1 to 1.5%. And they are okay to use again. In 2013, the FDA lifted the prescribing restrictions associated with rosiglitazone. That said, there are still some contraindications. Heart failure, osteopenia, osteoporosis, and then pioglitazone only has an association with bladder cancer. At the bottom here is the study, the record study, which was done in 2009, that really showed that the TZDs don't seem to have an increased risk of cardiovascular disease. TZDs are associated with an increased fracture risk. They seem to decrease bone formation and may lead to increased bone destruction. And then diabetics already have some altered bone mechanics. So a number of studies have shown this causal link between TZDs and increased fracture. So the take home is really avoid these in patients with a history of osteoporosis or osteopenia. For heart failure, they lead to fluid retention, which causes edema and weight gain. This is dose dependent and time dependent. Net weight gain for most patients is 3 to 4 kilos, so it's not inconsequential. That's about 8 pounds. And the majority of weight gain is from the fluid retention. The specific contraindication is actually with the New York Heart Association Class 2 and Class 3 heart failure. The counter-argument being that maybe they're okay in Class 1 and Class 2 heart failure, but I think most people would say if you have a patient with heart failure, probably avoid these medications. And then there is this concern about pioglitazone and bladder cancer, and the concern is that pioglitazone use increases the risk of bladder cancer. It was seen in studies of male rats. The cohort studies really have shown, in humans, have shown mixed results. But at this point, if a patient has a history of bladder cancer, active bladder cancer, don't prescribe pioglitazone. This was not seen with rosiglitazone. So a little summary on these. The side effects of TZDs make them less appealing to start as initial therapy or even add-on therapy, but they're pretty efficacious and they're really cheap. They decrease the A1C pretty reasonably, and I think they're worth considering again, especially if cost is a concern to a patient. For our patient, Mr. Jones, he has no history of CHF, no history of osteopenia or osteoporosis, and no history of bladder cancer. And with his cost issues, a TZD might really be a good option for him. So, next, case 4. This is Mrs. Brown. She is an 82-year-old female. She has had type 2 diabetes for 6 years. She's on metformin alone. Her A1C is 8.9. She's pretty frail. She's got a BMI of 19, limited mobility. She lives alone, and she's also peeing a lot because of higher blood glucoses, and she doesn't like that. Again, for her, even accounting with age, her A1C is too high. Goal is closer to 8 if we can get there without risking hypoglycemia. What meds might be a good option for her? We need something safe with a low risk of hypoglycemia. She's not interested in injectable. We really don't want to make her pee more because she's already complaining about that, and we don't want to dehydrate her because she's already pretty frail. So for her, a dipeptyl peptidase 4 inhibitor actually might be a good option. This is an oral medication. There's a low risk of hypoglycemia when used as monotherapy or with metformin. There is some risk of hypoglycemia if you're giving it as an add-on with sulfonylurea, so you may want to decrease the sulfonylurea dose if you add this on. Weight neutral, which is good. We don't want her to lose any more weight. Remember, her BMI was 19. generally really well tolerated. There is a possible risk of pancreatitis. Use has been associated with pancreatitis, but there's not a cause and effect relationship at this point. So the DPP-4 ultimately decreased glucagon and blood glucose levels. The mechanism of these is they increase incretin levels, so the GLP-1, glucagon-like peptide, and the gastric inhibitory peptides, which inhibit glucagon release, which also increases insulin secretion and decreases gastric emptying, thereby bringing down blood sugars. So here's our table again. So they're intermediately effective. Their A1C reduction is usually between 0.5 and 0.8. So not significant, but maybe enough. Very low risk of hypoglycemia, weight neutral, rare side effects, but fairly costly. They actually are running between $330 and $400 per month. So again, these are the medicines that end in gliptins, your alogliptin, linagliptin, saxagliptin, and sitagliptin. And they do need to be renally dosed, except for the linagliptin, and pretty pricey. But for her, this actually might be a really good choice. The sulfonylureas just don't seem like she's 82. We really worry about hypoglycemia in her. The SGLT2s and the GLP-1s are associated with weight loss and are less well tolerated. The GLP-1 is also injectable, which she's probably not going to be that interested in. For her, she's frail. You know, we don't know if she has a diagnosis of osteoporosis or osteopenia, but we really probably don't want to think about a TZD with the risk of fractures. And then again, her A1C goal is really probably closer to 8%. You know, she was 8.9. If we can get the full effect of the DPP-4 inhibitor, we get the 0.8%, that would get her to 8.1, and I think we'd all feel reasonably happy with that for her. So, all right, case 5. Mr. Hendricks is a 65-year-old male. He's had diabetes for 12 years. He's currently on metformin, glipizide, pioglitazone, and insulin, glargine. A1C is 8.2. He has a history of a prior heart attack, hypertension. He's obese, he's a smoker, and he has a history of pancreatitis. And he has recently noticed increased dyspnea on exertion and dependent edema. And you get an echocardiogram, which shows a diagnosis of CHF. So what should we do with them? And what are our options? So for him, we probably need to stop that TZD. And with his history of pancreatitis, avoiding a GLP-1 and possibly the DPP-4. So maybe we think a little bit about those SGLT2 inhibitors. So these are the medicines that end in gliflozin. And they work by increasing urinary excretion by interfering with the reabsorption of glucose in the proximal renal tubule. They inhibit the sodium glucose cotransporter 2 in the proximal renal tubule, disrupting reabsorption of glucose. So they act right there. And these came about actually there's some groups of families that have familial glucosuria, and they've been found to have this genetic condition where the SGLT2 lacks activity. And these people don't develop hyperglycemia or type 2 diabetes, and there doesn't seem to be any obvious secondary clinical problems or physiological compensation. So in this, familial cohort of people who are lacking that, we had a natural place to start thinking about other ways to treat diabetes. Currently approved SGLT2 inhibitors are canagliflozin, dapagliflozin, and empagliflozin, all with great brand names, Invokana, Farxiga, and Jardiance. The main side effects of these meds are urinary tract infections and mycotic genital infections. They do have a net weight loss, and they have a very slight reduction in systolic blood pressure of 1.3 to 7.3 millimeters of mercury for the systolic. They also have a pretty low risk of hypoglycemia because they act independently of insulin, and they need to be renally dosed, and they are also very expensive, so $375 per month. Of note, they're saying their A1C reduction is 0.8 to 1.2. Again, that's probably going to be lower if you're adding it on as the third or fourth agent. They act independent of insulin and insulin resistance, so you're really just peeing out blood sugar or peeing out glucose. The main side effects are the UTI and the yeast infections. There's also this association with an increased LDL, and what that ultimately affected, it's not clear. There's also a possible bladder cancer association with dapagliflozin and hyperkalemia with canagliflozin. The biggest thing that's been coming out recently is this euglycemic DKA. So there's an association with a euglycemic diabetic ketoacidosis, and it's the consequence of this non-insulin dependent glucose clearance, hyperglucose and volume depletion. The thought is it's due to urinary glucose losses do not vary even in the time of stress when other mechanisms are putting more glucose away. So your blood sugar levels are going to be normal, but the cells are actually starving for glucose. This seems to be primarily in preoperatively in patients who are on insulin plus an SGLT2 inhibitor. And the big recommendation for this is that if you have a patient on an SGLT2 inhibitor and they have nausea, vomiting, metabolic acidosis, or they're having Kussmaul's respirations, you need to look for ketones to see if they're having a ketosis. Preoperatively, these meds need to be stopped 3 days. So most other medications are stopping day of or the day prior. These need to be stopped 3 days prior. And if they are having emergent surgery, be prepared to have them on both an insulin and a glucose strip, and monitoring that blood sugar closely and monitoring for ketones. So, take home, intermediate A1C reduction of about 1%, low risk of hypoglycemia, net weight loss. Main side effects are these GU infections. Be really cognizant of euglycemic DKA. Hold these meds 3 days preoperatively. And they're pretty expensive, so having that conversation with your patients. All right, so case number 6, Mr. Penn. This is a 53-year-old male with a history of diabetes, presents for follow-up. He was diagnosed 2 years ago. He has well-controlled high blood pressure. He's on metformin, lisinopril, simvastatin, and aspirin. His A1C is 7.9, creatinine 0.79, BMI is 29, and he asks you about the lizard spit drug, and he wants to know how it works. So what is the lizard spit drug? These are the glucagon-like peptide 1 inhibitors, which is an incretin. So the incretins are hormones that regulate blood sugar. The problem is the human version has a really short half-life. So if we were to make a pill or something to mimic the human version, you'd have to be taking a pill several times a day. However, the Gila monster spit, there is a similar hormone that's much longer acting. It is now synthetically derived, so they're not actually getting lizard spit. But these are the GLP-1 receptor agonists. And these work to increase glucose-dependent insulin secretion, which is really important, right? If we are going to have insulin increase, but it has to be when there's glucose around, so it's much more sensitive and less risk of hypoglycemia. Decreases inappropriate postprandial glucagon secretion, slows gastric emptying, and decreases food intake. In animal studies, they may also be showing some cardioprotective effects as well as increasing beta cell regeneration. So these are another one that we may hear more about. These are pretty effective medications. They can decrease your A1C from 0.8 to 2%, that low risk of hypoglycemia. There's an associated weight loss. Pretty expensive. They're $500 to $700 per month, and they're injectable. So for many patients, that's less appealing. The net weight loss is due to slowed gastric emptying and decreased food intake. And the weight loss is usually between 5 and 7 pounds, so modest but real. And the injectables are done either daily or weekly. And so we'll go into that a little bit more. So short-acting versus long-acting preparations. The long is actually often preferred for convenience. This is a once-a-week injection. You also want to be careful with the short-acting for patients with gastroparesis because it does seem to, the short-acting has more gastric slowing, emptying slowing effects Some need to be reconstituted, so the patient actually has to mix things. Insurance coverage is probably going to dictate primarily which meds you use, but patient preference may have a little bit there. So this just kind of shows that there are some variabilities. So if you're more concerned about fasting blood sugar control, the intermediate and the long-acting formulations may be more effective. If you're looking at postprandial glycemia, then the short-acting may have more effect. Both are pretty effective at controlling the A1C. The short-acting either has to be daily or twice a day injections, and the intermediate or long-acting are weekly or once a day. And these you can actually use with insulin as well, which some people do. So this is how they come. They come in a pen. A couple of them do have to be reconstituted, so that'll be what it looks like. And so there's some mixing that the patient will need to do. The two here that need reconstituting are Bydureon and the Tanzium, or so the long-acting exenatide and the albiglutide. So keeping that in mind for patients. So Mr. Penn, he chose to do the dulaglutide, or Trulicity. He liked that it was once a week and he didn't have to mix anything. He calls you 2 days after starting the med, and he has persistent nausea and he's been vomiting. He doesn't have any abdominal pain, fevers, or chills. So what do we tell him? So GI side effects are the are the main side effects of these GLP-1 inhibitor receptor agonists. And so nausea, vomiting, and diarrhea occur in up to 40% of people. It's dose dependent and should decrease over time. It may recur each time you increase the dose, so you have to kind of prep patients for that. And the management is to decrease the dose and then slow that increase with that. The other adverse effect that we have to really watch for is pancreatitis. So acute pancreatitis has been reported with the GLP-1 agonist treatment. Some studies are suggesting increased risk, others don't. The risk seems to be low. Studies have shown 16 cases in 14,562 patients. Currently, we're saying don't use these in patients with a history of pancreatitis. There's also a few other reports of pancreatic and neuroendocrine tumors. The FDA is saying at this point there's not enough data to support that. There is a black box warning for medullary thyroid cancer. These are based on, there were tumors seen in rodent studies and not in humans. The GLP-1 receptor expression on C cells in human thyroids is actually significantly lower than in rodents. But for right now, the recommendation is don't use these in patients with a history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. So GLP-1 agonists reduce blood sugar through multiple mechanisms. They're not first-line therapy at this point, but can be combined with oral therapy or basal insulin. They can be really effective at improving the A1C, about 1%. The data from the companies is saying up to 2%. The pros are pretty low risk of hypoglycemia, and they're associated with weight loss. Cons are high cost, and then the side effects can be pretty intolerable. These can be really good to think about for some of your patients who you're sort of feeling like they might need to move toward insulin, but they're not ready, or they're forgetting mealtime insulin, or they're busy travelers, or if they're truck drivers who can't be on insulin, this may be effective. The weight loss piece, there is that added benefit, and of note, liraglutide is also marketed at a higher dose, up to 1.8 milligrams per week, and that's been branded as the brand name Saxenda. All right, so just to kind of review all these, we reviewed almost all of these. Metformin is cheap, it's effective, it's first line, and it's cardioprotective. Extended release formulations have less side effects, and we can probably liberalize its use in renal insufficiency, start using GFR and not hard and fast creatinine. TZDs are safe to use again. They're cheap and effective, avoiding congestive heart failure and osteoporosis. Sulfonylureas are also cheap and effective, but they have a limited duration. High risk of hypoglycemia. Be really cautious in the elderly and CKD. The DPP-4s are expensive, less effective, but very safe. The SGLT2s are expensive, less effective. There's a risk of GU infections, and we really have to keep our eye out for that euglycemic DKA. And then GLP-1 receptor agonists are expensive, very effective, associated with weight loss, have pretty profound GI side effects. Don't use with a history of pancreatitis or a history of medullary thyroid cancer. There are some other approved medications, but they're not really widely used and not included in the ADA 2016 algorithm. And these are the alpha-glucosidase inhibitors, the meglinides, the bile acid sequestrants, and the dopamine agonists. Typically expensive, not well tolerated, and minimally effective. I think we may see some more on particularly bromocriptine down the line. There's some studies coming out saying that there may be benefit in cardiovascular endpoints. But right now, the data is not there. There's also a whole bunch more coming down the pipeline, so we may be adding more to that algorithm in more letters. But there's some anti-glucagon agents, there's glucokinase activators, and this imeglimin, which may decrease hepatic gluconeogenesis and increase muscle glucose uptake. So more coming. Be prepared to be more overwhelmed by the alphabet soup of diabetes. And I just have one last point, that using the A1C, I think it's really easy to just kind of use the A1C to think that it accurately matches your patient's blood sugars, but there's actually lots of limitations, and up to about 14% of patients is inaccurate. Anything that's increasing red blood cell turnover will result in lower values. Iron deficiency can lead to an increased A1C. Blood transfusions obviously affect it. It also, despite being a 3-month average, most closely reflects the month prior. So about 50% of that reading is the prior month's blood sugars. And really just if the blood sugar readings that the patient's doing or that you're getting in clinic or on your routine labs are not matching the A1C, you may want to start thinking about other ways to monitor their blood sugar using some other tests. That A1C will be accurate for that patient, meaning that an A1C of 7.9 means 7.9 for that patient, and if it goes up or down, you know you have tighter or less blood glucose control, but it may not necessarily mean that 7.9 means that their average blood sugar is 150 for that specific patient. So, and I think the end. So, I think that those were the objectives, and there's just two things that I would really recommend as references. Is there's a 2016 Abridged for Primary Care Providers document of the American Diabetes Association Standards of Medical Care and Diabetes. And then in late 2015, American Academy of Physicians also published a nice article, Management of Blood Glucose with Non-Insulin Therapies and Type 2 Diabetes. And then there's lots of other references, but we'll stop there. So, thank you.
Any questions?
Locations. Is there one standard method for doing A1Cs now? I know in the past there were several different.
No, I mean, yes. The best A1C, so checking an A1C, a point of care A1C is going to be less accurate, and there probably is some variability between companies, but if you want the most accurate A1C, it's going to be a blood draw. But no, there is not like an INR or something where it's standardized, no.
C was so good.
Yeah.
But up here I've been chastised because it's not so hot.
Yeah. So, and I mean, we'll even see that occasionally. I've had in clinic where somebody's A1C has come back way out of whack, and I'll recheck it in clinic on the same machine, and it'll come back a point or two different. So I think we really do have to be a little bit cautious, but right now the point of care A1C is a really nice tool, but I think if you feel like it's not matching what the patient's reporting for blood sugars, it is going to be really important to start looking at not using the A1C as the hard and fast rule for guiding your management. Yeah.
All
Thanks,
right.
everyone.
Thanks very much.